Hello, everyone. My name is Pablo Otero, and I welcome you to the webinars organized by MidVet Academy, talking about regional anesthesia. We are going to provide a series of seminars talking about different approaches, but before to start to speak about specific techniques, we are going to speak about the fundamentals of regional anesthesia, and we are going to focalize in a special points in order to organize our setting and to provide a step-by-step general technique. So let's go with the presentation. We do have different types of techniques to provide regional anesthesia. The most commonly, perhaps, are the neuraxial blocks through epidural and spinal anesthesia. We already have the peripheral nerve blocks. That means the injection of the local anesthetics around the nerve. For this kind of block, the needle should be practically in contact with the nerve. So we have the nerve here, surrounded by this epineuron. Generally, the nerves are between muscles in intermuscle spaces or between fascial structures. So we have here the muscle, and the needle should pass through the muscle and reach the perineural space to make the injection. As you can see in my draw, my rudimental draw, that the needle should be so near from the nerve. And for that reason, the technique we use to make peripheral nerve blocks should be a meditated technique in order to avoid the main potential problem related with peripheral nerve blocks. That means the lesion of the nerve with the needle. We do have also a new generation of interfascial plane blocks, in which the injection of local anesthetic is performing in an intermuscular or interfascial plane where the nerves or plexus are present. So, in these cases, we have the belly of the muscles, and our needle should reach the intermuscular space where we know the nerves we want to affect, to block, are present. It is common for this kind of blocks to inject or deposit a huge volume of local anesthetic, huge in comparison with the volume we use for a peripheral nerve block. That means a single injection. As we can see in the film, the regional anesthesia allows us to perform mostly any kind of procedure if we design a desensitization which involves every single tissue of the region we want to invade. However, our techniques are not designed to desensitize all the tissues related with the surgical area. We use to apply regional anesthesia as part of a general anesthesia. That means as a multimodal approach for general anesthesia. So I like to speak about blocks, not regional anesthesia, because regional anesthesia is a full desensitization. But when the blocks are used as part of the general anesthesia, we can appeal to the effect of the other drugs administered during anesthesia. That means the systemically drugs injected during premedication or even during the surgical procedure as part of the whole protocol. However, and let me see again another image, we are performing in this case invasive procedure in a sedated patient. Of course, this is not a huge surgical procedure. We can perform this work with the animal in lateral recumbency, which is a comfortable position, but with only a small sedation. As you can see, the animal awake immediately after we finish the surgical maneuver, and the animal is able to walk instantaneously. The meaning of this image is just to share the information that when it's performed correctly, the block is able to desensitize all the area. However, and again, and again, and again, we used the blocks routinely in an anesthetized patient, which is safer, which is more comfortable for us because we don't need to deal with an awake animal. But again, as you can see here, when we introduce the anesthetic blocks in the surgical procedure to bring analgesia, to reduce the nociceptive reaction during surgical stimulus, we can diminish the other drugs, and the animal awake super comfortable because of the residual analgesic effect of the local anesthetics and the lack of systemic drugs. We can say that the introduction of regional anesthesia in the anesthetic protocol reduce the amount of general anesthesia, and this has been shown it is related with a diminish of risk related with general anesthesia. Mortality rate in patients treated with local regional anesthesia are reduced compared with animals in which same procedure are promoted or performed without the help of the blocks. So let's go to see how to perform the block itself. First, and again, we can perform the blocks using different techniques: blind techniques, nerve stimulators techniques, which is also a blind technique, and ultrasound-guided technique. When we compare the efficacy of the different techniques, we realize about the high rate of fail of blind techniques. So nowadays, we already have the possibility to use the new tools, that mean ultrasound, nerve stimulator, to reduce the fail of the block. And when we perform studies or when we read studies performing to compare blinded to ultrasound guide techniques, we can see that even in super trained hands, the rate of fail is huge compared to the successful rate of the ultrasound guide techniques. And it is important then to bring this tool to our setting to reduce fails, to improve the performance of our procedure. Okay, as I mentioned, the nerves, which are a complex environment of different nerve fibers, organized as fascicles, and of course, and again, surrounded by this peripheral membrane, which is the epineuron. Here we have the muscles, and remember the needle should pass through the muscle, pierce this membrane, which is the epimysium, to reach the perineural space. The perineural space, it is located between the epimysium of the muscle and the epineuron of the nerve. Many times we have also some fascial lips in between. So the needle should pass and pierce the epimysium, because if we don't pierce the epimysium, the injectate will distribute around or between the muscle fibers. And of course, the amount of local anesthetic reaching the nerve itself will be low and perhaps an efficacy. And so remember, we need to deposit the local anesthetics perineurally. And this is the goal, to enter, to violate the epineuron is not allowed it. And that's again and again is a good reason to introduce tools that allows us to see the tip of the needle, the belly of the muscle, and the nerve itself. In case we enter to the nerve, we pierce the nerve, can happen different scenarios. We can make the injection intrafascicular, which is the spasting, because the pressure we generate during injection will compress the nerve fibers, promoting lesions. If we have lucky and the needle is located between the fascicles, it is still dangerous because there is vessels, and we can pierce this vessel, promoting hematomes that will make compression around the fascicles, promoting lesion. So keep in mind two important things. The first, we need to stop the needle near the nerve, but we need to avoid needle nerve contact. It's mandatory to keep in mind that we need to allow this interaction, which is super important in our setting, because the nerve we blocked in a small animal, dogs and cat, are super small. But we use the same needle physicians use for humans. But the relationship between the needle and the nerve we use to block is the one we are seeing in the screen. So if we goes to the nerve and interact with the nerve or pierce the nerve, perhaps we are going to break the nerve, which is not good at all. And keep in mind that the needle we used, although are traumatics, when touch the nerve, make small lesions. This lesion will promote inflammations. This inflammation will promote a cicatrization, and this whole situation can finish in a nerve damage. We don't have still information about the rate of complication related with the blocks with regional anesthesia in veterinary medicine. However, there is some reports that show that minor problems are important and huge problem, super adverse effects, like the one we are seeing in the screen, although not frequently at all, can be present. So we need to improve our technique in order to protect the nerve, because in the worst scenario, if the block fail, we already have the option to use some rescue analgesia through systemic administration. In order to improve our precision, we can combine techniques. The blind techniques, nerve stimulators, and ultrasound. That means to be aware about the anatomy, to use our hand to determine the landmarks, to enter the needle with the ultrasound, but use the nerve stimulator to certify in advance the present or the absence of nerve fibers. The present, when I want to certify that the dot in the screen is the nerve I call nerve. And to certify the absent, because many times the needle should pass through tissues where there are fibers, nerve fibers, motor nerve fiber, that I don't want to pierce or to break. So the combination of ultrasound and nerve stimulator can improve not only our efficacy, but also to help us to reduce potential complications. Well, we have a lot of different techniques that allows us to desensitize every single region of the whole body. Thoracic limb, pelvic limb, thorax, abdomen, head, etc. We are going in the next webinar to speak about the different approaches. Of course, we are going to speak about the most useful and important in order to desensitize appendix, thorax, abdomen, etc. But no matter which block we are going to perform, we need to make a standardization of our technique. So our first step will be study or be familiar with the anatomy. Anatomy, it is important. It is important because finally we have a three-dimensional world. This three-dimensional world, it is formed by the different anatomical structure. In the screen of the ultrasound, we are going to see only two dimension, but if we know correctly the anatomy, through the different movement of the proof, we will be able to reach the spaces, the tissues, the nerves we are looking for. Just to mention, we don't have a lot of studies in veterinary medicine, but in human medicine, we know that the learning curve needed to learn to perform correctly a block, that means to reach a successful rate of 80, 90, 100%, needs a lot of attempts. For instance, when we talk about epidural, we need to perform between 60 and 90 procedure to reach a successful rate of 80%. So as you can see, the stir we need to scale to reach confidence, to learn to do the different approaches. It is hard, but relax. You will be able to do it because you just need to practice. Here again, now for the brachial plexus, 62 to reach almost 90% of success. For us veterinarians, perhaps it's a little bit hard because physician has always some specialists or trained people teaching you every single day how to do it. This can be a reality in university hospital or big clinics, but perhaps in small setting we are alone, so we need to be ready to be patient, but to have a routine, step by step. We will be able to reach the hill. Okay, just to mention, around 40 blocks, we start to reach the plateau. Okay, keep this number in mind to avoid any anxious situation during practice. The second step is related with the knowledge of the tool we use to improve our practice. As I mentioned, we have two important tools. For sure, ultrasound, it is the rock star of this chapter, but we already mentioned the use of nerve stimulator. Nerve stimulator is a device who allows us to send to the needle a current. The current has, of course, specificities that give us a feedback between the relation between a feedback about the distance, between the tip of the needle and the nerve. Of course, the nerve we look for should have motor fibers because this electricity will promote myoclonus. Okay? So as you can see, we have two electrodes. The needle have a cable which send the electricity and have an extension line that we use to make the injection of the volume. This extension line, it is very important and useful during the practice of the regional block because as soon as you reach the place, the needle should be still, immobile. And during injection, if the needle is attached directly to the syringe, you can move the syringe, the tip of the needle and touch the nerve. So the extension line, it is mandatory. And the nerve stimulator have three different buttons or settings. One to set the intensity, the duration of the stimulus, and the frequency. The frequency, we can measure the frequency with hertz. That means how many stimulus by second we are going to have. 1 to hertz means 1 or 2 impulse per second. The duration, 100 microseconds. This setting is used to despolarize the motor fiber, not the sensory fibers. So we set 100 microseconds just because with this duration of the stimulus, we don't promote pain, we just promote myoclonus. And finally, perhaps the most important, it is the intensity. We measure intensity in milliamperes. And we know that there is a relation between the milliampere we need to promote the myoclonus. So as close as the nerve we are, less milliamperes we need to evoke the myoclonus. So we know that if we have myoclonus with 1 milliampere, we are around half centimeter of the nerve. And if we have myoclonus with 0.5 milliampere, we are practically in contact with the nerve. And if we have myoclonus with 0.2 milliampere, that means we are inside the nerve. So if the answer is absent with 0.5, we need to go closer to the nerve. If we have myoclonus with 0.2, we are inside the nerve, we need to withdraw the needle. Because to pierce the nerve, it is bad. It's not good at all. But if you make the injection inside the nerve, the consequence will be dramatic, devastating. So there is rule. We are going to speak about the rules to avoid intraneural injection, but should be follow this rule every single time we make injection. And finally, our ultrasound. We need to be aware about how to handle our ultrasound. We need to learn how to use every single button, because this knowledge will you help to improve your image. And of course, a good image is the key of a nice or good procedure. Because if you don't set your ultrasound to visualize your nerve, perhaps it is not the better. Well, we attach the probe. As you can see, we have different type of probes. The linear, convex, microconvex, etc. And we use specifically the probe we need for every different or single block. You already saw that I moved this one, which is the setting to change the gain. Remember, we have a specific presets in the ultrasound machine. However, many times we need to organize a little bit more the visualization of the screen, and we can use the gain to make more visible the structure we are looking for, or to differentiate accordingly nerves from muscle, from fascia, etc. So gain, it is one of the button we need to be, we are going to use routinely. Another important setting is the depth. As you can see, when we have a depth screen, perhaps our target, it is in the top of the screen. So ideally, we need to fit the target in the middle of the screen, just to be aware about the landmarks of the anatomical structures around, and to individualize our target. So gain, to see the tissues; depth, to set our target in the middle. And finally, the direction of the probe. This is, at least for us, super important, because if we set always the marker of the transducer in the same direction, we will see always the same image in the screen. When we put the probe in the tissue, we are going to have 4 cardinal points. This one, this one, this one, and this one. This point is always the place where I put the probe. For instance, if I put the probe here, yeah, here, yeah, this is the medial aspect of my arm, okay? So this will be medial. If this is medial, this is lateral. But if I put my marker facing laterally, or cranial, yeah, this will be cranial. But if I put my probe in the opposite, this can be caudal and not cranial. So in order to fix the setting and to organize our image in order to get always the same orientation, the probe should be oriented lateral, cranial, or dorsal. Okay? We will specify this for every single block we are going to learn together. But keep in mind that one of the most important things, before touch the body of the animal with the probe, is to realize about the position, orientation of the marker of the ultrasound. Okay. Here you can see we are making a scan of the lateral aspect of the leg. So this is lateral, this is medial, and this can be cranial or caudal. But because we follow the rules, this is cranial. Okay? Perfect. Cranial. As I mentioned, we can use different probes. The most useful and common in regional anesthesia are the linear probes, because the linear probes allows us to see a wide scenario in the superficial tissues. However, many times we need to make blocks in a depth position, or we don't have a lot of space to set or put or located our proof. So many times with the linear proof, we don't have space to enter with the needle. In such a cases, the convex probe can be a good replace, a good option. Remember that the convex proofs make visions in a depth position. But for the blocks, for sure, we will use this part of the image. So different proofs. Ideally, we have to be able to use both, depends of the block and the animal we need to treat. It is also important to be aware about the different setting of the ultrasound machine, especially that who allow us to save our procedure. This it is super important, not only to give information related with the procedure we perform, but also to make a retrospective analysis and to help to complete our learning curve. Even we can share information. Many times we use to send our blocks or attempts to college who give us the feedback in order to determine if there is some error or the outcome of the patient can be related with the procedure we perform. So introduce the of habitus to save the information related with the different procedure you perform. Okay, let's go. Perfect. Okay, needles. This is perhaps an cornerstone discussion related with the regional anesthesia. Perhaps you know that there is a lot of companies performing different kind of needles, and every single needle, that's mean every single size, every single length, every single tip, it is performed to or developed to perform different techniques. For instance, hypodermic needle are developed to pierce and to pass through tissues without resistance. Of course, if a hypodermic needle reach a nerve, will pierce the nerves without any problem. So the needles we used in regional anesthesia, that means the one will interact with the nerves, have a special bevels that not allow but reduce the probability to pierce not only the nerve but the vessels around the nerves. So try to use these technical needles which are developed for the technique we are going to perform. We have different kind of needle. We have the spinal needle. The spinal needle are developed to pierce the dura mater, which is a part of the tissues surrounding the spinal cord. We have the TUI needle, which are developed to set catheters. We have the sprout needle, pencil point needle, which are also developed to enter to the subarachnoidal space. And many times we use this needle in veterinary medicine to perform different blocks. However, ideally, we need to use the specific needle, that means the one developed for regional anesthesia. We have different kind of needle. We have the needle who allows us to make a stimulation with the nerve stimulator. We have already needle who had some treatment in the body, which enhance visualization with the ultrasound, of course, are amazing. And the tip of the needle of this needle has a bevel of 30°, which is good enough to enter, but good enough to allow lesion of vessels and nerves. So try to use this kind of needle when performing the different approaches we are going to speak about in the follow webinars. Okay, we are going to follow with the tips and tricks to perform our procedure. One of the important things is the ergonomic setting of our technique. It's super important to be aligned along our visual axis with the ultrasound and all the setting we are going to use to perform the block. Then ideally, this should be the orientation. The practitioner, the needle, routinely the needle is handled by the dominant hand, the probe, which is handled with the non-dominant hand, the animal, and the screen or our ultrasound machine. So I can see all the scenario without moving my head. I can see every single thing, my hands, the needle, the probe, how the needle align with the probe in order to see the needle in the screen, and the screen itself, just moving the glove of my eyes. So this is important. Take all the time you need to organize your setting before to perform the block. And try to reach or to work in a comfortable position, avoiding this contortionism. For instance, if I want to make the block and I have my dot here, I need to see my needle, see my probe, and see the monitor. I can't see all together, so I need to move my head and my hands separately. Doesn't work. It has been shown, even in veterinary medicine, that this setting reduce complication, reduce time needed to perform the block, and increase efficacy. So this is the way to do it. As you can see here, yeah, my eyes, needle, probe, dogs, and the screen of the screen of the ultrasound. We can also make a simple exercise. We have the probe, which is over the dorsal aspect of the ilium. So this bone we can see here is the ilium. This is dorsal. This is ventral. And my question is, where is this cardinal point? Do you remember our guideline? This can be lateral or medial. Should be lateral. So the marker of the proof is fastened laterally because we are scanning the dorsal aspect of the region. Okay, I mentioned before that we have 3 dimensions, but we only see 2 dimensions in the screen. And I already mentioned that the movement of the proof will help us to reach this structure, this space, this landmark, which is not present in the screen. We can move, slide transversally, longitudinally our proof to look for the place we are looking for. Movement help us also to improve the image. Remember that as tangential, as vertical, the ultrasound beam pass to a tissue, more visible will be the structure. However, and pay attention to this tip. However, we need to align the needle with the ultrasound beam. Should be parallel, because if not, we are not be able to see the needle. If we tilt our probe to get a nice image, picture, we won't be able to see the needle because the needle cannot align with the ultrasound beam. For that reason, the ultrasound beam should be always perpendicularly to the skin. So use tilt, for instance, to enhance the image, to realize about the position of the nerve or structure you are looking for. But to treat the needle, you need to be perpendicular. Okay? This is important. You need to learn to negotiate between a beautiful image and the image allows you to follow the needle. We have different type of approaches or needle handle. The most common, it is the in-plane approach. That means we enter parallel to the ultrasound beam, as we can see in the field. With this in-plane approach, we will be able to see the needle all along its walk. We are going to see the body of the needle. We will be able to see the tip of the needle. And as you can see, our target, in this case, the sciatic nerve, the fascias around, and the distribution of the injectate in the intermuscular or interfacial plane. Remember, as the angle you use increased, the needle will be more tricky to identify or visualize in the screen. So try to organize your setting in order to reach the proper angle. That means the angle that allows you to visualize correctly the needle. Another option for the approach, it is the out of plane approach, which is we don't use routinely, but we start to introduce the out-of-plane approach in different blocks. When we use the out-of-plane approach, we only see the tip of the needle, the tip or the body of the needle. So we need to learn how to differentiate the body of the tip and the tip. As you can see, we will see some like a brilliant dot in the screen, which is the position of the tip. We used to follow the tip as the tip runs till the injection point. Pay attention to this. We have here our dot. Okay, this is again the sciatic nerve. In this case, we are making a cranial approach. It is an out-of-plane approach. We are reaching the intermuscular space, cranial to the sciatic nerve. So let's see. We can see in this image two things. First, that we are using the nerve stimulator. Can you see the contraction of the muscle? And the needle walking till the intermuscular space. As soon as we reach the intermuscular space, the movement of the nerve fiber, the muscle fibers disappear because we are not anymore inside the belly of the muscle, and we can see the tip of the needle in the intermuscular space. And here we can see, for instance, an application of these dual guidance, ultrasound and nerve stimulator, to determine the interfacial plane, to help to find the interfacial plane. Okay, we are reaching the end of this first webinar. And we are going to make a quickly view of the how to setting our devices when we use the nerve stimulator or ultrasound to perform the block. When we use the nerve stimulator, we connect the insulated needle, turn on the nerve stimulator, and we preset the setting in 0.1 millisecond, 100 microseconds, 2 hertz, and 1 milliamperes. Remember always to follow the safety of the procedure with monitor, be ready to treat any complication, etc. Okay, so we advance with the needle towards our target nerve. If we reach myoclonus with 1 milliampere, we reduce the milliampere to 0.5. If we don't have a myoclonus, that means the nerve is here and the needle is running far away from the nerve, we need to reposition the needle. If we have response myoclonus with 0.5, we need to reduce to 0.2, just to be aware if the needle is near the nerve or inside the nerve. If we have myoclonus with 0.2, we need to withdraw the needle. But if we don't have myoclonus, we perform the test to be sure that we can perform the injection. First, aspiration test to see if blood appears in the half of the needle. Then we make a small injection, a liquid of the anesthetic, to realize about pain, about nociception, because intraneural injections are painful. Even if the animal is under anesthesia, you need to watch the monitor and be ready to detect any nociceptive response. That means tachycardia. And to be sure that there is not resistance to the injection. Because, as I mentioned, if the needle is inside the nerve, you need to distend the intraneural space, and this promote resistance. So, not injection if blood appear in the half of the needle, not injection if there is some painful reaction during the handle of the needle, not injection if you need to make force. That means if you perceive resistance to the injection. If everything is okay, we make the injection of the calculated volume. When we use the ultrasound, we need to scan the area to identify the zone anatomy. And if we are going to perform the combining technique, we connect the insulated needle and we turn on the nerve stimulator, but in this case, we reduce the milliamperes to 0.3. Why 0.3? Just because we want to detect if the needle touched the nerve, but we don't want the movement of the screen during the approach. Okay. We advance toward the nerve, we are watching the nerve, and the question is, are you able to see the needle and the target? If you cannot see all together, you need to align the transducer until the needle and the nerve are visualized. Remember, if you don't see the tip of the needle, ideally, you cannot move your needle because it can be dangerous. If you can see the target and the nerve, you can increase your milliamperes to 0.5 to determine if the structure you call nerve is a nerve. If you don't reach any myoclonus, you need to reposition the needle. But if you have the myoclonus, that means the dot you call nerve is the nerve, you make the test. Aspiration, the small aliquot of anesthetic to see the distribution. You are using the ultrasound in this moment, and avoid any injection if resistance is founded. Finally, if everything is okay, you make the injection. Here we have the whole algorithm just to give the final picture all together. So we are arriving to our final words. Thank you so much to be here. As I mentioned, we are going to provide a series of webinars talking about different approaches. We will focalize in thoracic limb, pelvic limb, thorax, and abdomen. See you then in our next webinar. Thank you so much to be here.